Thank you so much for joining us. I have the distinct honor of introducing Dr. Juliet Edgcomb for this much-needed grand rounds titled Clinical Text Mining with Large Language Models, New Tools for Understanding Pediatric Suicide-Related Service Use. Juliet Edgcomb, MD, PhD, is a child and adult psychiatrist and the Associate Director of the Mental Health, Informatics, and Data Science Minds Hub at UCLA's Semel Institute. She is an assistant professor in residence of child adolescent psychiatry in the UCLA David Geffen School of Medicine. Dr. Edgcomb's work bridges youth suicide prevention and clinical informatics. Her research develops computational models to detect and characterize child-adolescent emergency service use for suicide and self-harm, recently earning her the 2024 Clurman Prize for Exceptional Clinical Research. Her research is funded by multiple foundation grants and NIH K23 award. She also serves as the physician informaticist for the UCLA Health System. Personally, Juliet is one of the most exceptional, talented, and brilliant physician, researcher, and human that I know. I'm inspired by her daily, and I'm honored to be introducing her today. Take it away, Juliet.
Thank you, Dr. Khan, for that wonderful introduction. It's wonderful to be with you all today to share this topic and some new insights coming from our Mental Health Informatics and Data Science Hub here in Semel. I'm going to start by grounding the problem that I'm going to talk about today. In the United States, suicide is the second leading cause of childhood mortality after age 9. And with that sobering statistic, in fact, if you add up the 4th through 10th causes of death, the total is less than 2/3 of the number of suicide deaths among young people ages 15 to 24. Emergency department visits for suicide and suicide-related reasons rose in the decade between 2011 and 2020 by 12% among teens and 27% among preteens. While we saw some drop during the COVID pandemic, there's been a slowed but continued rise over the last few years. The cost of non-fatal self-harm, emergency department visits, is over $510 billion a year, with 10 to 24-year-olds accounting for a lion's share of the costs. So how are we doing here at UCLA? Well, if you use a tool called Slicer Dicer, which is available in Epic, you can look at how many children under 18 are coming into our emergency rooms for suicide-related reasons over the last few years. So this graph shows 2015, around the time ICD-10 was adopted, through 2024. You see a rise. And if you split by adolescents and preteens, the numbers mirror what we're seeing on a national level, with some slowing during the COVID pandemic, kind of in the middle of this graph, and a rise overall. So whether it's at a national or a local scale or even global, awareness and detection of suicide-related service use is really important for driving the types of interventions we study as researchers or offer as clinicians, resource allocation, staffing, and quality improvement. As I have this little picture of a target up at the top, detection of any illness is a core feature of precision medicine, the right treatment to the right person at the right time. It's a first step. And missed detection of service use is problematic from an individual risk stratification standpoint and from a population health standpoint. And we've known this for decades. The National Syndromic Surveillance System and other national efforts have supported detection of geospatial clusters of suicide-related conditions, and this map is showing suicide and self-harm mortality as a heat map. And efforts like this have enabled very specific targeted interventions. So for example, in one geographic area, it was found that there was a rise in adolescent girls overdosing on over-the-counter medication And so in that area, blister packaging was implemented so that there was less access to kind of rapid lethal means. So it's just one example of how geospatial awareness at a population health level can be useful. From an individual risk stratification standpoint, and if you're a trainee and you've staffed with me on call, one of the first questions I ask is, what is the history? What is the history of suicide attempts? What's the history of non-suicidal self-injury? How severe was it? How bad did it get? And of course, I'm asking that because it is one of the known strongest predictors of future suicidal behavior. And if we miscalibrate or are not aware of past suicidal behavior in some way, that is going to have a downstream implication to our risk formulation and the actions we take as a clinician. That also applies if you're feeding that information into an algorithm that's guiding your decision making, but it applies in a concrete sense in any clinical scenario to be aware of that prior event. So precision prevention is difficult without precision detection. So let me go back to my picture here. Okay, this looks convincing that there's an increase in visits, but let me zoom in. So how did I define who's coming in for a suicide-related visit? Well, you can see this red circle. I did what is usually done, which is I sorted our data set, meaning all of UCLA Health Emergency Department encounters, by their primary ED diagnosis and their chief complaint, and then restricted to children. And the reason I did this is because it reflects what we commonly do, whether it's at any kind of public health application or even risk stratification. We use ICD code and chief complaint. So there is a great paper, and I encourage anybody who's interested in suicide research or even from a clinical standpoint to take a look at Holly Hedegaard's paper that came out a few years ago, where she discusses how we define non-fatal self-harm and non-fatal suicide attempts using ICD codes. And there's an appendix in that paper that lists hundreds of codes, which in turn have been grouped and used over and over again to define, here are the suicide-related visits. And she points out in this paper, there's a number of limitations to this. One being, for most of these codes, intentional self-harm does not specify whether it includes intent to die or not. So it's very difficult to distinguish what is non-suicidal self-harm from what is self-harm with suicidal intent. Now this is the provider, of course, assigns the ICD code. But on the flip side, the other piece of information that's often used is the chief complaint coming from the youth or the family. And this is what the National Syndromic Surveillance System uses, is let's look at what the patient or youth said they're coming in for. And if you follow this forward, most EHR risk predictive models define non-fatal suicide-related outcomes using ICD codes, sometimes also chief complaint. And with the exception being some particularly well-done, well-funded studies will go and ask the patient themselves, which of course is the best way to do it. But for the top two, it's really representative of a lot of efforts to try to dive into medical records and characterize a population who's experiencing suicidal distress. Now, the concept of getting better at defining a cohort of interest using data from EHR is really not new. We're really late adopters in psychiatry, and particularly in child psychiatry, for over a decade. Cancer, diabetes, genetic disorders, rheumatologic disorders, asthma, these conditions have defined and detected through unique combinations of EHR data who has these conditions in a data set. But we can also intuit that the methods we use to detect the lab abnormalities that characterize diabetic ketoacidosis really extrapolate poorly to characterize amorphous presentations of distress in a preteen or in childhood and adolescence. And there's both clinical and methodologic challenges. Here I'm highlighting some of the clinical ones. One, suicide is transdiagnostic. The vast majority of children who come in for suicide-related reasons uh, may not have even been seen before for a mental health concern. And you're left in the shoes of a generalist ED clinician who needs to make a decision on how to label this visit. And that leaves a lot of room for provider interpretation, for variability in training, for stigma to come through. And most children who attempt suicide are never seen by a mental health specialist in the emergency room. So if you think about multiple informant narratives, when the patient's mother said they overdosed on Benadryl intentionally, and the teenager says, no, I didn't. I had a headache. I had a rash. How, how do you code that? How do you label that when there's some degree of uncertainty? And then moreover, children, of course, are not static and they change over time. And they also may have axes of neurodivergence in the way they're presenting with suicide-related concerns or self-harm. A few examples of synthetic cases, but you may, if you see kids, you may have recognized these scenarios or similar ones in the past, where you have in the top one, a 15-year-old with ODD tries to grab a police officer's gun saying, just shoot me. A 13-year-old with major depressive disorder, worsening depressive symptoms, has a suicide attempt through electrocution. A 17-year-old male comes in with some symptoms of maybe some psychotic symptoms. So I put these scenarios up here because there's something in common about them, which is that they don't really have any key words. They don't have the words suicide, they don't have the word self-harm. They're pretty heterogeneous. The context is critical, the informants differ, and the underlying diagnosis is likely different. Further, if you imagine a similar scenario that occurs in an adolescent versus a preteen, depending on who's writing the note, the situation may be described very differently. So for example, a 15-year-old female, sudden onset suicidal ideation, attempts suicide by asphyxiation with a seatbelt, but a younger child, that same scenario may be described as wishing she was not alive and made a suicidal gesture by pushing a seatbelt against her neck, right? So there's, depending on how you frame a situation, that child might actually end up with a different diagnostic code, and certainly a different profile within their EHR, a different note. Beyond the clinical challenges, there's also methodologic ones. One is what I'm going to call the iceberg problem. I'm going to define that in a moment. Another is an emphasis on text, of the idea of there's no way it's in the structured data. We have to look in the notes. The notes are going to tell us the answer. And also getting at the heterogeneity in detection, that children are not a one-size-fits-all entity. So what's the iceberg problem? The iceberg problem refers to the idea of when you're going to try to figure out who in a population has a certain disorder, you could run an algorithm or whatever method you want to use. It could be ICD code, it could be the text, it could be anything to try to figure out who has the disorder. And then you give each of those people a certain score of how likely they are to have the disorder. You take your top scorers and you check, you look in the record, you say, did I find them? And usually the answer is yes, you did. You chipped the top off the iceberg. And we see this over and over again in the literature, where these huge data sets are mined. And this comes predominantly from the idea that we can identify cohorts with great specificity, but maybe not care too much about sensitivity. And we confirm, we have a confirmatory check that yes, these people did have this disorder. But my question is, who are we missing? Who do we never know comes in for a suicide-related reason, for whom it's buried in the note, for whom they don't get the structured data, and for whom it's much harder to tell that they were there and in need. There's a great paper, Jennifer Boggs from Kaiser Permanente Research Institute put out a few years ago on a critical review of text mining applications for suicide research. And in that paper, she shares many efforts that have gone into looking at text in notes in order to figure out who's coming in for a suicide-related reason, spanning adults and children. One recent example is a group that came out. They used a NLP system called BERT, which was sort of the latest and greatest in NLP a few years ago. This paper came out earlier this year in Journal of Biomedical Informatics and used the MIMIC database. So these are adults, ICU adults, trying to identify types of suicidality that are present in the notes. And essentially, most of the ways that these natural language processing papers set things up is you take your note, you put it into a classifier or some sort of algorithm, and it pops out with a probability that that note, or rolling up to the patient level, had a suicide-related reason for the visit. But after years of these locally trained, expensive, labor-intensive natural language processing algorithms that I'm summarizing in one tiny box here, but encapsulates years of work, we have the new kid on the block. And this is a somewhat facetious picture of a llama, because one of the first open source large language models that enabled the use of a generative pre-trained transformer, things like ChatGPT, but with no internet connection. So the note stays secure. And this has been a big area of interest recently. But before we go there, I want to put on our skeptic hats here and think for a moment if going to text, if mining text is really the right answer. And the reason I want to sensitize you all to this is because mining text is computationally intensive. It requires a good setup, and it's not something that you go into with when resources are more scarce. And so this is, has been a pause moment of most of the work that, Jennifer Boggs described in her review. It stays in a research context and it doesn't move beyond that, because text, especially child mental health visits, are not really easily shared among institutions, validated across institutions, and are very difficult to extrapolate to our less resource settings. So a question that our group had early on is, do we really need the text? Or is there something in the structured data that could be a better indicator than ICD codes alone to try to figure out who's coming in for a suicide-related reason? If you think about something like an elevated acetaminophen level, well, that's not going to detect everybody, but if somebody does have that level, that's a pretty strong indicator that maybe we should look twice. So we ran a pilot study that came out in JMIR Mental Health a few years ago. We looked at 600 youth, and we had humans, research associates who were trained in labeling the notes. They labeled the notes and then labeled the visits as to whether they were suicide-related or not. And then we used various forms of structured data to try to pull out who had a suicide-related visit. And it did pretty well. But we also noticed something a little bit strange, which was that sometimes for some children, the detection was better, and for other children, the detection was worse. And so this raised a train of thought of, well, is detection of suicide-related service use really a one-size-fits-all problem? And I alluded to this earlier, that I don't think it is. And in fact, if you look at data on suicide deaths, of whether a death is ruled a suicide or unintentional, there's more errors in Black and Hispanic individuals than in white. So something is going on here where there's a potential for differential misclassification, and that coupled with, in our pilot data, we saw we weren't detecting boys as well, and we weren't detecting younger children as well, that maybe we need to pay more attention to the heterogeneity in who is accurately detected and who is not. So this launched our study, our series of studies that we call Child Suicidality EHR Phenotyping, or CSEP, and we try to detect suicidality, characterize who we are not detecting by either commonly adopted ways or any new ones we come up with. Then we move to how do we detect interventions who gets safety planning, who gets lethal means restriction counseling. And then I'm going to touch just a little bit on kind of thinking outside of the box for child psychiatry and EHR. Okay, so first, the task of detecting suicidality. So we developed a study in which we took EHR across our hospitals here at UCLA. And over the course of about 4 years, we labeled nearly 4,000, 3,800 emergency department visits and all of their clinical notes for the presence and type of suicidality and non-suicidal self-injury, classifying them using something called the CCASA, which is a standardized method of labeling whether suicidality and what type is present in clinical documentation. This is just a flow chart to show how we derived our sample. And it's important to know that early on, we split off about 700 of these children at random to dive into any kind of classification model that we'd want to train. And we left the other 3,100 sort of fresh and not touched, so we're not training any of our models on that data set, only on the 700. This is a slide to show the CCASA. We adapted it for children and for emergency department encounters. And we looked at a few different options for trying to detect whether the visit was suicide related or not, whether it was related really to self-injurious thoughts and behaviors or not. We used in orange features derived from notes, in blue features derived from structured data, and or both. And simply put, we put these features into a classifier. That classifier outputs a probability that that child's visit is suicide related or not. And we compare that to what the human thought when they looked at all the notes for that encounter. Not all structured data is equal in its complexity or ease of access. So we laddered the structured data so that we looked at sort of a low complexity version where you just use ICD code and chief complaint, similar to what's currently used in most suicide risk prediction models and syndromic surveillance efforts. We used a mid complexity, which included Columbia scores and mental health related diagnostic codes, and then a high complexity, which was about 300 or so structured data elements, laboratory tests, demographics, area deprivation index of the zip code, etc. And so we put that into a classifier, just structured data, and this paper came out last year in JAMA Network Open. And in that study, we were able to show that, first of all, preteen children, we do not detect very well with ICD code at all. And there's variation in who's being detected. And so this paper kind of really drove home the idea that when you're using ICD code to find cases, especially among younger children, there's bias that's coming in. We're not detecting everybody equally. So this project then moved to the notes phase, and we had the maybe good or bad fortune of doing this right when LLMs were hitting everywhere. And so we actually did a traditional NLP where we had humans label individual sentences. So I think it was 800,000 sentences by hand, and locally trained a model using sentence vectors and an approximate nearest neighbor network, which generates essentially a score for each note as to how likely that note contained suicide-related statements. And then we also, in parallel, did a large language model approach where we wrote a prompt and gave that prompt along with the note to an open source LLM, a llama model. This should be a good moment to say I have no commercial disclosures, and this model is available completely for free. And we shared the prompt and the note, and we said, output a Likert type score. So let's see how these did. In a little bit more detail, this is the traditional NLP model. You take text, you tokenize or split the text into sentences, you convert the sentences to numerical representations or embeddings, you plot those sentences in a vector space, and then you assign their neighbors' vote on whether the sentence is suicide related or not. That's the traditional way. And then we have our large language model way, where we put in our text along with a prompt. We used our 700 held out encounters and got our prompt better and better. And when the prompt generated a Likert score using something called function calling to reduce what the model can actually output, you force it to give you a score. We compared those scores to the human criterion. And when we started to see good AUCs, we then converted over to Llama 3.3, the larger model, and we fed it the unlabeled notes, or the notes that it did not know whether they were suicide related or not, and compared and got the Likert score out there. So again, this is sort of the framework. And if you translate this into what we found, so at the top row is the simplest, okay? So the blue is the structured data. Top row is the simplest, the ICD code in chief complaint. And you can see the accuracy 0.56 and the AUROC of 0.86. Then if we add in the Columbia, we do a bit better, 0.88. If we use only mental health diagnoses, we do a 0.80. If we use all structured data, which is that ACS, we get 0.86, which is quite a bit better than ICD code alone, just using structured data. And then when you put in the orange, which is the notes, you start to do even better. And when you use both the notes and the structured data, you do best of all, capping out with an AUROC of the combination of all structured data and the language model with an AUROC of 0.977. So this is a picture to show if you look at what's called the permutation importance. In other words, if you take all of the possible things that your model uses to figure out whether it's suicide related or not, and you sort them by how important they are to the classification. In other words, if you took out that variable, how much worse would the model do? Like, how much is the model relying on that variable? This is what you see. On the left is our traditional NLP, and you can see one of the highest ones is the traditional NLP score, and the second one is the ICD code. And then if you look at the Llama model, though, this guy who's all the way out here on the far right, that's the LLM score. That's the Likert score that comes from the out-of-the-box LLM looking at the note. Okay, so this is cool, but it doesn't answer the question of for whom do these methods work better or worse? Are they fairly detecting children, or are they detecting some people worse than others? And are there some individuals who are missed or not being classified correctly? So we took our sample of 3,000 children, and we had the advantage of having a ground truth, having the entire iceberg, right? Because a human read every single one of those 3,100 notes and assigned a label. So we're not sorting by top scores and checking the top scores, but we're looking at really everybody. And we stratify by sex, by race and ethnicity, by age. And I've sorted in that first column AUROC, so that's an indicator of how accurate the classification was, where 0.5 is chance and 1 is perfect. And I've color coded here to help with reading, where red is worse and green is better. And as you go across the columns, you're going through our different potential ways of detecting children, whether it's through structured, notes, or combined. And you can see that the ICD code chief complaint, who does it miss? Who is not getting the ICD code? And I think it kind of fits with our clinical practice, which is preteens and boys. And as you go further down, interesting that of girls, Black girls are getting a AUC of 0.84, whereas if you look down at the bottom here, some other groups are being detected 0.94, 0.966, 0.93. And so there's this wide variation, right, in who we're picking up on in that first column if we're using ICD code alone. And as you move forward to the right, look at this column at the far right, and we can see here that not only are we doing better kind of overall, but our numbers are getting closer together, right? So there's less variation in who's detected and who's missed. You can do the same exercise using underlying diagnosis. Again, suicide transdiagnostic. There's a huge variation in who is coming in and how they're presenting. And what do we see here? The children who are not well detected with ICD code and chief complaint tend to be those who have intellectual disability, disruptive impulse control disorders, psychosis, developmental delay, autism. And who do we detect well? Well, children with depression, right? Substance use anxiety, some OCD, some trauma. We tend to do much better. Interestingly, though, even when you use the language model and you use all the structured data, that far right column, still there's a disparity when where we're not detecting as well children with the disruptive disorders, right, 0.858, and children with psychosis, 0.867. So I asked GPT, just kind of out of curiosity and for fun, to make a picture of what it thought of the study. And it's kind of eerie, right? Of the invisible kid, right? As a preteen boy. And that maybe they're fading away in the waiting room. That's actually what GPT came up with to label it. That we're not picking up on some kids as well as others. Okay, I'm going to go to the next part. I'll try to keep it brief so you have time for questions. So, the next stage of the study, we started to get interested in like, okay, if we can pick up on who's coming in for suicide-related reasons, what was done about it? And, if you think about the interventions that are recommended, National Strategy for Suicide Prevention, AAP Blueprint, lethal means restriction, safety planning, caring contacts, 988, all of those things are in our notes, right? They're not really in our structured data. There's been some efforts around safety planning, but really all of the information on what the clinician did, other than hospitalize or don't hospitalize, is lost. And so for children who are discharged, we don't know who is being counseled on lethal means, who is given a D. Hirsch crisis follow-up phone number, right? Kind of simple things, but also very concretely important. And so we decided to adapt our method to manually review the records, read the notes, label what interventions happened or did not happen, and then try to see if a language model could pull it out. And so we did a little pilot where we looked at 200 human labeled notes and 200 human labeled children and all of their notes. So there's thousands of notes for those 200 children. And we labeled whether the intervention was present or not. And we compared how well the automated way of finding the interventions did compared to the human labels. And then we looked a little bit at, well, do the odds of intervention vary based on some properties of the child? Who is more or less likely to get safety planning with lethal means restriction, et cetera? So these are just some examples of how we annotated, and we used an analogous method of give the text. The prompt is, instead of saying, is this a suicide attempt? Is this self-injurious thoughts or behaviors? It's saying, was there an intervention? Did this intervention happen? And gives some acronyms and some the one on the left shows the best practice prompt with defining some acronyms and defining some details, and then how we adapted it for each of the different interventions. And bottom line is what we found is the language model does a really good job of figuring out whether an intervention was offered or discussed or not. And in fact, if you look at then who is more or less likely to receive an intervention, we found some interesting things. For example, children who had prior 90-day or 180-day ED use, and for whom they were not asked as many screening questions, as many Columbia questions, they had half the odds of receiving safety planning and lethal means counseling. So small study, still something we're kind of playing around with, but I think kind of plants the seed of, can we detect these interventions more clearly and then figure out who's getting them and who's not. And then I'll just leave you with a few thoughts here on how do we think about, as a specialty, a little out of the box with how we think about the data that we are de facto generating in our clinical practice, and how do we use that, extrapolating from what is typically a medical or surgical application to adapt it really for our specialty, to know what are the needs, what are the questions, where are the gaps in knowledge around our clinical practice, and how do we leverage the data that's right in front of us for good, to identify potential areas of bias, to uncover areas of bias. How do we interpret what are the core studies that are coming out, with that knowledge that sometimes the way things are operationally defined really does matter for the conclusions drawn. Just a small pilot study we did was looking at involuntary detainment, because now, of course, our involuntary detainments are captured in notes in Epic. So you can pull the notes and look at, what were the reasons given for the 5585? Who was put on a 5585? And when we started looking into this question, it was amazing how very little is out there on this topic, using EHR at scale to try to identify really kind of important gaps in what we know about our clinical practice. So where is this going? There's a fabulous scientist who's actually, I think, is the highest H index of any researcher, Ron Kessler. He's at the VA and he's a suicide researcher. And he put out this great opinion piece in JAMA Psychiatry on pragmatic precision psychiatry, the branch of precision psychiatry focused on matching patients to the best currently available interventions. And I think when we hear that, we might think of, pharmacogenomic studies and kind of that level of more of a biological focus. But I encourage everyone to think of this also from a health services standpoint, and how do we identify what is the right treatment for the right patient at the right time. And so this is where we're thinking of going, of developing these precision treatment rules. And in order to do that, we have to be able to measure outcomes, right? Who is coming in for a suicide attempt? Who is experiencing that adverse outcome? What interventions were done? And then we can start to identify which interventions worked better or worse for some people. And if we can say something or find something about the quality of the intervention that was delivered, that's also helpful and a piece of this. I'll leave you with one last thought, which is, in trying to make headway here, one of the early criticisms I got is never call the clinician note the gold standard, which is fair. At best, it's a silver standard. Trying to understand what is the reality of the clinical scenario through the lens of a clinician who wrote a note. And really the best case scenario would be to ask the patient what really happened. So we have to have that level of humility that, like, look, the note is not the end all be all. But, we use what we have available, and to know that the notes that we write are potentially being used to change the way we deliver care, right? To have that awareness, it's a cycle, it's a learning health system. And even the structured data we put in, right? And things are changing. As you may have heard or directly use ambient AI, right? Our notes are increasingly written by a model, not by ourselves as clinicians. And most of the outcome metrics around ambient AI are provider satisfaction based? Did it reduce pajama time? Did it help you complete your work faster? Did you like it? And I'm really wondering, to what extent does that generated note reflect the reality of the clinical scenario? Is it better? Is it worse? And I think we simply don't know that, maybe the note is better. We get closer to the gold standard, that gold one I have on top, and we're better able to get high quality notes for all our children. Or maybe it's worse. And I think maybe most concerningly, is it better or worse for some people versus others? And we don't really know the answer to that yet. So it remains a question. All right, that's all I have. Thank you, and glad to answer any questions.
Thank you so much. This was an amazing conversation about the use of, large language models and how the clinical data can be mined and can be used to identify the risk for suicide and then, the next steps in terms of intervention and outcomes. I have so many questions, but for folks who are watching us, put your questions in the Q&A section of the Zoom screen, and we will be able to get to some of your questions. But just to get us started, as you mentioned, in terms of clinical note is one thing. So I have a two-part question, I will say. Clinical note is one thing. What would you want clinicians to do more of in terms of what should they be more aware of when they are documenting? Or also more than just the awareness, what are some of the ways that they can change their behaviors in their notes? And the second part is that, you mentioned that clinical note is one thing, and then there's lived experience of the patients, and how do we capture that into, the work that you're doing or any kind of large language model work that will be done to identify risk for patients?
Yeah, I'm hearing a two-part question of what should clinicians be more aware of, and then the community input. So I can address both of those. So in terms of what should clinicians be more aware of, I've reached given talks before like this, and people have asked, well, can't we just change what clinicians do? Like, just tell them to put the ICD code for suicidality if that's what's so important. Like, we could change that. And yes, I mean, that's one avenue, but I would argue clinician behavior is quite difficult to change. And if you think about kind of all the different types of clinicians that children and child mental health interface with, that's a tall order, though I think one that could feasibly be helpful. But I think in the interim, what's most helpful, and where I think is really important, to develop a sense of the idea that your clinical input into somebody's health record, whether that's through what you click on, what you message them, what you put as a note, all of those things can come back to support really good things, right? Like population health efforts directly for that patient. There's more and more clinical decision support. So if you enter something into structured data, that impacts where something else pops up in their chart. If you put one thing on their problem list, then maybe you'd be cued to do X, Y, Z, which could support an evidence-based intervention to help their care. But on the flip side, with great power comes great responsibility. So if there's an error, that can also cause problems. And, I think about, just in the case of suicidality, a suicide-related event occurs. Are we always aware of it when we are documenting? Or are we maybe not aware of something that happened in the past? And so to be very careful when you're putting in a, denies XYZ, to just know that it could just live in narrative text and it goes, it doesn't go anywhere. But we do have that responsibility to think about the validity of the information that we enter and sort of that stewardship of that information. The other thing you mentioned is lived experience, and I think they go hand in hand. And so what our group has done, in a small way, though I think there's increasingly global efforts to really try to integrate youth and lived experiences, we have established a community advisory board. We meet quarterly, if not several times a year. And we have representation from several leaders in community organizations such as Didi Hirsch, Healthy African American Families, Teen Line. And then we have quite a few youth now who we started with one, and we've gotten more and more youth. And actually, in 2 weeks' time, we're hosting a youth innovator event where youth are going to come and talk to us about their perspectives on AI and suicide prevention. And that's always very fascinating because I think, as all of you have likely heard or encountered, there's so many varied ways to think about, this very broad topic of AI and how does that impact care. And I think youth do have a lot of strong opinions about it, and we need to listen to them.
Absolutely, absolutely. Okay, we also have Dr. Brandon Ito's question in the Q&A section. He's asking, do you see a way to code clinician, race, gender, specialty, or other things to see if any clinician factors contributing to counseling or treatment bias?
That is a great question. We have some information on the clinicians. What's also interesting is when a kid is seen in the emergency room, right? There's many clinicians, right? So we have the notes from social work, the notes from nursing, the notes from psychiatry, if they're consulted, the ED physician. And so there's a situation where we don't just have one provider and that provider's demographics, where I think we only have gender and specialty. But there's could be 10 providers, right? The nurse could change shifts many times. And so I love this question because I think it's kind of where things could go next in terms of trying to really tease apart who is inputting what information into the chart. And actually we have an offshoot of this project where we're really honing in on errors and when do errors get introduced. And for that, we're really trying to look at least clustering by provider, whether certain specialties or locations or provider volume, like what's their expectation of what they're doing, and when those errors come in, not from a M&M standpoint of pointing the finger of blame, but to get a sense of where can we better support and introduce clinical decision support to kind of correct those errors.
Yeah, absolutely. Those are like great next kind of directions. On the topic of next directions, uh, you mentioned something along the lines that after the suicide risk, there is also potential of seeing like regarding 55, 85 or like involuntary holds. Will there be, other things on the radar? Because I've heard some, you know, people talk about risk for aggression that can be kind of like noted in the ER, substance use risk that can be kind of like looked at from the LLMs. Are there other things on the horizon that we should be aware of?
Yeah, I mean, I think if anything, the danger may be the other direction of now we're kind of given a tool where it's not that difficult. I don't mean to minimize it, but it's not that difficult to prompt an LLM to ask it, was this in the record? Was that in the record? Are the parents divorced? Was the child aggressive? And you end up with this laundry list of tens, if not hundreds of things you could pull out of the record. And um, I would just be cautious that how are we validating how well the model picked up that information? And do we really have the sample size of human labels to check, right? I think we all may be guilty of, and there's been studies to support this, that language models can be very convincing. And when they're close, but not quite right, we might accept that as ground truth. And so I think we have to be very careful with this unsupervised kind of determination of what's in the notes, because then we don't know when is it making errors and is there any bias in those errors.
Absolutely, yeah. Because I think one of the criticism of LLMs is also that it encodes the human bias into the algorithm as well, and it kind of like exacerbates then the biased outcomes. So on that note, like where do you think these models do fall short, or how what should we be worried about?
Yeah. Um, there is a pretty good literature on a generalization and that models can talk in generalities, right? If you are a domain expert on something, you're much more likely to pick up that there's an error than if you are a novice at it. You know, if I go to a model and I ask it to explain deep sea fishing, it's going to look quite convincing. But if I go to it and ask it, you know, what is the difference between a preparatory act and a suicide attempt using standardized terminology, I'd probably find several things that I don't like about what it's describing. And so, you know, I think we have to be kind of think about that. When do we need to train our own model? And so in this study, we're using out of the box, like literally it's a very short amount of code in order to get things going, and we're not training a model. We're not training an LLM. We're not making a new LLM. We're using an out of the box one. But there are folks who are training them, who have said, look, it falls down too much in certain areas. We're going to train it. And I think there you have to be careful about institution specific data. You know, is there good external validity? Is whatever you trained it on going to work somewhere else? So then it introduces kind of a whole other suite of questions. And then you know, related to what you had shared about the community input, there is something called red teaming, where people try to get the model to mess up. So you can pretty quickly get any model to generate synthetic notes, right? So you give it a template and say, make 200 notes about XYZ. And then you can insert difficult scenarios, ambiguous scenarios, and then see, you know, how well did it do with those? And so with community-based co-design and efforts to integrate community input, you can think through what are the tricky situations, like the kid says it was not an attempt and the parent says it was. How does the model reconcile that?
Those are important points. The work is cut out. I think there's a lot of excitement in terms of LLMs, and it's again promised. It's become the promised land of some sorts, but caution uh, needs to be exercised here as well. I don't see any more questions. So, folks, if you have questions, oh, there is one. Is there any way to account for the burden the clinician feels with the EHR demands and the resulting superficial note writing?
Yeah, well, I mean, that's a great question. And I think harkens back to Dr. Khan, your first question, which, you know, do we put this on the clinician and say, like, look, you've got to write these beautiful notes because someone's going to look at this for research and find that it's, you know, I think we have to be reasonable in what we're asking for. And I think that this is where kind of the ambient AI push came from of like, look, clinicians are working past hours. They're writing these really long notes. Now we have open notes, right? So all our children, their notes are accessible if they're under 12 or 13, and our young adults. So there has been this shift toward more and more burden on the clinician. And then I think that's where ambient AI steps in and says, like, look, this is going to be a relief of this burden. Um, but I think, you know, with any of these things, we have to be cautious and think through validity. And I think that's where my, and I don't mean to be a Debbie Downer, but I would go for a shorter note that's more accurate, right? And how do we really ensure the validity of what we're entering in so that we support quality of the work we do? And I don't have a perfect solution for it. There's no golden ticket, but I think just an awareness of how the landscape is evolving.
Yeah, absolutely. I think note bloat is a real thing, and I think a lot of information contained in the notes is just for the reimbursement purposes, right? So kind of like that has taken priority over everything else in some ways. Dr. Lynn also had like a two-part to this. She's mentioning that there are worries about the 1984's worry about tracking the clinician-patient encounters and those interactions. Uh, so any thoughts about that?
Yeah, I mean, thank you for that point. You know, as somebody who looks at suicide related surveillance, and then we have, you know, media input around surveilling other conditions, you know, tracking who has what mental health disorder. That's where you get very quickly into a skepticism of, wait a minute, when is this helpful? When is this not? And what sticks in my mind hearing these sort of comments is actually, I was part of a panel with an individual who, a researcher who is focused around detection of autism in notes. And she had a community advisory board member co-present with her. And that person shared, I don't want to be detected. I don't want to be outed. I don't want my dermatologist to know my mental health condition. And I think we have to be very careful of when is the information, if we're pulling information from the person's own record and we're going to display it at some later time to inform clinical decision making, we have to be very cautious about those 5 rights, right? Of right information to the right person at the right time and the right point in their workflow. And we don't want that information to sort of leak unnecessarily, even within a record. Even, no deep state person, no external person is looking at your record, but who are the providers who need to know that information? Who are the providers that don't need to know? And that's definitely something that weighs in my mind, and I think something that community voices help help with.
And I think there was a lot of like worry on the clinician side as well. I remember having conversations when ambient AI came in that, they would be hearing the encounter and how can that be used in litigation later on. And I think a lot of these, platforms tried to address that concern by saying that, okay, only for 30 days or for a month, the encounter will be stored and then it will be kind of like, removed from the databases. But then again, there is that concern even on the clinician end that how the encounters are can be used uh, in real time. Okay, we have like 1 minute to go, but I think we have answered most of the questions. So, any final words or anything that you would want to say?
I think I just, if this talk was at all of interest to you, to empower you as mental health providers and clinicians and researchers to speak up for our voice as a specialty in informatics. Things are moving very quickly now, and it's a time where I think we, as a specialty, as a subspecialty with child mental health in particular, really can contribute a unique perspective and something that I think will shape our practice in the future if we can get it right.
Thank you so much. And thank you everyone for attending. So, yeah.